What's going on, everyone? Dr. Todd from the Move Now Chiropractor. I'm here with a good friend of mine, Dr. Jeffrey Cronk from SmartInjury Doctors. DCJD, that means jurisprudence. That means he went to law school. Okay. Don't mess with this guy. He'll sue you. No, he won't sue you. But anyway, he's here and we are doing a podcast together. He's in Florida. I'm in Idaho. So we're using technology here. He's up on the big screen. And Dr. Cronk has been a wealth of knowledge for myself and hundreds of other chiropractors, probably been thousands at this point. He's been doing this for a long time in the personal injury space, but not just personal injury, just understanding injuries better, redefining yourself as a chiropractor, understanding what a spinal ligament injury is. Dr. Cronk, thank you so much for joining me.
Yeah, pleasure.
Before we get into it, let me roll the intro just so we can just go 100 miles an hour full speed ahead, because we got a lot of great stuff to talk about. So if you haven't heard of Dr. Cronk before, or you know who he is, you're going to love this episode. With that said, we're going to roll the intro. Here's what so many chiropractors have been searching for. How can we expand our clinical reach by finally addressing more than just the segmental component with our patients, but at the same time, not feel like we are selling out our chiropractic principles? The reality is our patients count on us to guide them. And when it comes to results, we must also address their posture and their movement. The verdict is out. Patients have spoken, and this is what they want and what they need, focusing on functional movement and corrective exercise. So how do we practice in a way where our community is engaged, excited, and seeking us out because of this comprehensive, results-based approach? That's the goal we've all been searching for, and this podcast will show you how. My name is Dr. Todd Pickman, and welcome to the Move Now Chiropractor. All right. What do you think of that? Pretty fancy, huh, Dr. Cronk?
Yeah, I love it. I love it.
Okay, cool. All right. So with that said, the first thing that I think we were going to talk about, just to jump right into it, is, not to sound negative, but how do chiropractors screw it up when they're taking on a personal injury patient? And I'll turn over to you and let you just elaborate on that.
Yeah. So, one of the things you and I talked about, and I guess before, first of all, I'm very appreciative for you to have me on your podcast. You're right. I've been in the injury market for a long time. I've done a lot of different things. I've set up 2 national spinal ligament testing companies because I still have the idea and the purpose to standardize spinal injury workups. You and I met. You had, found somebody that was in your program, that was in my program. You came in and, I mean, you gobbled stuff up because you understood, you had the basis foundation of rehab, and you understood spinal injuries. Your basis foundation was fantastic. You ate it up and then applied it. So obviously, whenever you have somebody that does well with your work, you really like that. But what was really nice for me is that you were so into rehab. And rehab is so important in the injury market because, 55% of the people that are injured in a spinal injury do not fully recover. And they should be treating with doctors that are in the front of the bell curve. I'm a big proponent, Todd, where if you have a spinal injury, you do not want to be in the middle of the bell curve with your treatment, because that middle of the bell curve has a name. And it's a name that I was once myself, I was mediocre. The middle of the bell curve is average. A great synonym for average is mediocre, right? Mediocrity is not what that patient needs. They don't need that. So first of all, I really appreciate the fact that, and I refer to you often, I think you're one of the top rehabilitation specialists in the country. I think you do a fantastic job. So that's why it's so easy to work with you, and it's so easy to blend right in. So I appreciate that. Now, when you say, hey, what are the 5 things, a way chiropractors screw up a injury case? First of all, chiropractors, and I know I said this before we started the podcast, chiropractors are in the position to be the top spinal injury doctors in the world.
And should
but
be.
We've been in that position for 30 or 40 years, but we really haven't taken advantage of it. And the reason why I say we haven't taken advantage of it is the size of a chiropractic market is 0.3 of 1%. So 1/3 of 1% is the chiropractic market in the healthcare market. The injury market is the largest market in the healthcare market. So injury market in 2013 was $820 billion. Today, that's probably double. So you're talking a trillion, $1.5 trillion, $1.6 trillion. Now that's not the whole. The whole would be 4.5 trillion, something along that size. So we're infinitely small. And when you ask me what are the 5 ways that we screw it up, the number one way that we screw it up is that we don't standardize our understanding of the spinal injuries. So, Todd, I'm going to ask you a question. You still there? Like, I don't know that I know this. Where'd you go to school?
I went to Cleveland Chiropractic College in Los Angeles.
Good. So did you go through a formalized program on spinal injuries?
Hell no. They didn't
Okay.
teach us anything about that.
Okay.
No.
Every doctor. Yeah, go ahead.
Yeah, no, I mean, none.
Yeah.
None.
So every doctor out there, every chiropractor out there has never had another. You can go to West, Life West. You have Dr. Dan Murphy. I think he's one of the top educators in the world, bar none. He's going to do some injury education with you. But in no chiropractic college in the country is there any standardized program on spinal injuries. Now, here's the kicker. There isn't one in any doctor of PT college in the country. There isn't anyone in any osteopathic college education in the country. And there's none in medical education either. So you have the most problematic condition. Spinal low back injury is the number one cause of chronic pain and disability, lumbar pain, low back pain. Cervical injury is the 4th leading cause of chronic pain and disability. And it's also the 6th leading cause, with headaches being the 6th leading cause. So you have the number 1, number 4, and number 6 leading cause caused by trauma. And if I want to go back, Todd, to like I had this textbook, and I'm kind of a junkie on some of this stuff. I had a 1915 textbook that said all subluxations were caused by trauma. It's caused by contact with the body in its external environment. It's never caused from within. I know there's a whole lot of theories about within and, hey, negative emotions are going to cause us.
You know what? On the same note, Dr. Gonstead also very simply said subluxation is caused by trauma. Like it's caused by some sort of physical traumatic event.
Correct. It's caused by trauma. So the foundation of the profession of chiropractic is trauma. The absolute foundation. Now, I think it's pretty ironic that it's not taught, right? So you don't have any curriculum on injuries. So when you say, what are the 5 ways that any doctor messes up a spinal injury case, is by not understanding the injuries. And there's only 3 of them. I mean, I know, Todd, you know, one of the things I like to think that we're live on a podcast. I'm asking this question live. We didn't prep for this. But when I say, hey, there's only 3 injuries, didn't that simplify it for you?
Yeah, totally. Yeah. And well, it simplified it for me, but also simplifies it when you go do a talk to attorneys or you talk to another practitioner, you know.
Oh my God.
Yeah.
So much, or even to a patient, you know what I mean? So a spine is bone and connective tissue. That's the makeup of a spine. It's bone and connective tissue. So if we say something is damaged or traumatized or injured, it has to be deranged. If a dog bites you, but there's no bite marks on your arm and you come screaming into a doctor's office saying, oh my God, look at this bad dog bite. And the doctor looks at you and it's like, wow, I can't see any derangement of the skin, the muscle, nothing. It's like, okay, maybe you got a bit, but you certainly didn't get injured, because in order to get injured, you have to derange something. If the spine is only 2 parts, connective tissue and bone, then derangement of a spine is either you broke it or you have connective tissue damage. The connective tissue damage is 220 specialized ligaments that hold all these joints and the vertebra together and also hold the discs in alignment, and you have 23 discs. So you either damage the support ligaments, which cause excessive motion and spinal instability, or you damage the disc, which causes disc herniation. So I can take those 3 things, fracture, excessive motion, and disc herniation. And if that's not understood, reimbursement's going to be bad. Getting involved with attorneys that are cutting your bills are going to be bad. Patient communication is going to be not as good as it could be. Patient compliance can go out.
So those are the 3 things then: is fracture.
Yep.
Disc herniation.
Yep.
And
excessive motion. So the support ligaments, when they're damaged, we pick that up with excessive motion.
And excessive motion is the one that people seem to know nothing about.
Yeah, it's the primary. So if you look, like when an attorney, a disc herniation, if I go to Medscape right now, anybody that's on this podcast, Google search Medscape. Medscape's like the #1 medical site in the world, and say, what are the indications of a disc herniation? And it's going to say there's 2 basic indications: pain and radicular pain. Wow. It didn't say headaches. It didn't say it didn't say headaches, dizziness. It didn't say any of the post-concussive syndrome type symptoms. It didn't say any of the referral type symptoms: shoulder pain, shoulder pain, scapular pain, mid-back pain. It didn't say anything about any of those other symptoms, right? It just said pain and radicular pain. So if you look right there, if we're diagnosticians, right? If I walk in, Todd, to your place and I say, hey, I don't care, you're a chiropractor. I say, hey, my chest is getting really tight. It feels really tight. When I go up 5 sets of stairs, I basically feel like I'm going to pass out. I get dizzy, and my ankles have been swelling for the last month. They look like elephantitis. They're really swelling. Those are called symptoms. Now you're going to relate the symptom to a tissue or to a area of the body. Obviously, in that case, it's going to be heart. You're going to refer me out to a cardiologist. You're going to go, those are common symptoms of a heart condition. In the injury market, the majority of conditions are a common condition for the support ligaments and not the disc herniation. But yet everybody's drunk on one of the things that drives me the absolute craziest is when I say the chiropractic profession should be the leading profession in spinal injuries, it's also the profession that's easily led. So this idea that everything is a disc herniation. Oh my God, everything's a disc herniation. Where does that come from? It doesn't come from any medical education, and it doesn't come from any good medical or chiropractic rationale. I can 1000% assure you of that. It comes from this idea that that's all an attorney knows. And so the attorneys want everyone to have an MRI. Now, I'm not opposed to MRIs. It's the only way you can tell if there's a disc condition. But it's not designed to pick up damage to the main injury that's there, which is a support ligament injury that causes spinal instability. That's the one that has the majority of symptoms. That's the one. If a person has a disc herniation, Todd, and I know you already know this, the first thing I want to know is, what are the support ligaments around that disc doing? I mean, are they tore up as well? I mean, let me lay another one on you, Todd, because this, while we're on a roll, you know, I can get out all my frustrations about the market with you on a podcast.
Yeah.
This is good therapy for me.
Good.
Like somehow a person's in an auto accident, right? And there's some smart bomb of energy. Ooh, it was an auto accident. There's a smart bomb of energy that just hits the disc and the disc herniation.
Yeah. How's that happen?
How's that happen? It's impossible for that to happen.
Right.
Right. So number one way is not knowing the injuries themselves and not doing a good workup for whatever injury is there. If you don't do that, your foundation of your claim is actually faulty. And that's going to allow people to cut your bills. It's going to allow you to cut your care. It's going to allow people to actually say you overtreated, you shouldn't have done this, you shouldn't have done that. And it all comes from just not having, number one, the foundation of the injury. So you're working up whatever injury the patient has, and you're working that condition up.
You know, having that knowledge builds a tremendous amount of confidence, and the confidence is what now allows you to not back down or be startled if an insurance adjuster or an attorney or someone else tries to challenge you, because you realize they don't know what you know. There's a tremendous amount of information that you get from diving in and trying to discover, is there a spinal ligament injury? Like, something that comes to mind, and this was a case that you helped me with as well. My associate doctor, Dr. Zach, a patient of his that he saw, you probably remember this. It got a little messy. This was a story of basically the wrong attorney taking a case, and then we had the patient, you know, well, that patient decided to then fire the attorney and get a different attorney. And the reason, this poor girl, she had significant injury. She had 4 levels of almost 4 millimeters of excessive translation motion in her neck, 4 levels in her neck, 4 millimeters plus on
Right.
each segment.
Tore
Yeah.
up.
Yeah. Awful. And her attorney, who I talked to, and I was just trying to give it to him on a silver platter to be like, look, when the insurance company says there's nothing there and there's no problem and it's just a soft tissue injury, so it's an ice pick in your testicle, right? Is
Yes.
it is I said, do you understand what's going on with your client's injuries, the patient that we even referred to you for you to represent? I didn't realize you didn't know this stuff. Can I go through and explain this to you so you can better understand this? And I went through and I basically just, like I said, just spoon fed this person and explained it, talked about AMA guidelines, what this means, what this is going to mean for her future. And this guy was just unwilling to basically take that information and comprehend it. Instead, he said, well, I just talked to the insurance adjuster and they just said, because there's only this much damage to the vehicle. And I'm like, you suck at your job, don't you? And so, essentially the patient, I relayed this to the patient. I said, here's what's going on with you. Your attorney is unwilling to take the information that we've explained and being able to represent that to the insurance company. So your options are either continue to go the route that your attorney wants you to go. You have every right to talk to your attorney, see if they're going to do something otherwise, or you can get a different attorney. And so she got on with him, fired him. We took one of our other attorneys who actually attended back in the day when you came out in person and you did the presentation at our clinic for one of our impact events.
Yeah.
It was one of the law offices that came and attended.
Yeah. You thought I was a little hard on him.
Yeah. Yeah. But whatever. Yeah, I know. I was like, whoa.
And I probably was.
It was funny. We had a handful of attorneys come attend. Dr. Cronk was doing a presentation for them at one of our impact events. It was a 5-day impact event that we did. It was like this massive, we had chiropractors fly out.
Phenomenal event.
We had a video crew there filming it. We broadcast it. We had like 30 or 40 offices watching this online. And anyway, on a Friday night, we catered this event, had attorneys come in. Dr. Cronk's there, does his presentation for the attorneys so that we could all see how he would speak to attorneys. And it was funny because it wasn't like, hey, everyone, come on in. It was like a drill sergeant and he's just going through and kind of putting them in their place and kind of, stirring them up a little bit. And at first I'm thinking, oh man, he's being pretty harsh to these guys. But ultimately it resulted in building trust and rapport, and they had good conversations afterwards. And this is one of the attorneys that we've continued to work with, that we took this patient who was being poorly represented by this other attorney. She fired the attorney, went to this other guy. This other guy, at the end of the day, took the information that we presented on the spinal ligament injuries, used that to confidently talk to the insurance company and said, no, this is a major issue. And ultimately the patient was able to get benefits that they were rightfully entitled to. They got a much better settlement, and everything went well, minus the new attorney having to deal with the old attorney. That was interesting. He shared with me some of that communication. I was like, man, these attorneys are just brutal with each other. I mean, just like F you and this and that. And I mean, writing nasty emails to each other and just trash talking. Something else too in that case, I'll just add, is that something else that we did is I had the patient go do a consultation with a neurosurgeon who I know. And this neurosurgeon knows that we understand spinal ligament injury and instability. Just to make sure, I even pointed out to the surgeon, I showed them, I said, look, this is the actual textbook justification for a fusion surgery when there's instability. And that's something that I got from you, obviously, Dr. Cronk, and showed that to him. And he's like, oh, yeah. And I said, and so here's how we measure this per the AMA guidelines. And here's how much instability she's got going on. So he does a consultation. This definitely helped because he documented that she's got massive instability. And at some point, she's likely going to need some sort of spinal fusion surgery. Now, we're not going to be sending her off for spinal fusion surgery because we're going to do conservative rehabilitation, but she does have a massive injury. Yes. The way neurosurgeons look at it, they have their hammer, everything's a nail. That's a perfect nail. but we have, I think, a better hammer to be able to fix a lot of this stuff so it doesn't have to go to that drastic extreme.
I'm feeling the therapy, man. I'm feeling the therapy already,
Yeah,
because
you feel good,
here's the
right?
thing. Yeah, no,
Yeah.
because that's exactly what I'm saying, Todd, is that look, in the market today, in the spinal injury market, one of the things I say is the blind are leading the blind, right? The blind are leading the blind. But if you can see, you can lead the blind. And that's exactly what you did. You took, okay, some attorney goes, oh, wow. The insurance adjuster said what? What, you talking about the 23-year-old insurance adjuster that just got out of college that, has been trying to figure out claims for the last 6 months. And so one of the things that's interesting, and doctors, if you're in this market, you have to put up with this. The personal injury attorney market is the only lawyer market that does not study the condition that it represents. Now, you got to let that sink in. Okay, if Todd and I are in a contract and I get injured with a contract, I'm hiring a contract lawyer. They spend their weekends, they do CE, they geek out on contract law. How do you break contract? What's the best language? How do you counter that language? They study everything there is to know about it, right? Imagine going to a contract attorney that doesn't really study contracts, right? Imagine going to an asbestos attorney. Let's say a patient's got asbestos exposure and you go to the asbestos attorney and they've never studied asbestos. They've never studied where does it congregate in the body? How do you test for it? How do comorbidities actually interact with it? What are the symptoms that the person sees with it? What are the standard workups for it? They didn't know any of that, right? You go to a personal injury attorney today, and this is why we have a program called Smart Injury Lawyers Program, but and it's for training for attorneys, and say, have you ever studied the injuries that you represent? And they're gonna say no. Now, their number one thing that they say is we rely on the doctor's notes. That's hey, this is our comeback. We rely only on the doctor's notes. Now, that'd be like a car. Remember, an attorney, and when I use car salesman, I want to preface it. An attorney is basically taking injuries and selling it to the insurer. They're taking the patient's condition and they're selling how bad it is to the insurer. So they're the salesman of the injury. They don't go to court a lot. They settle this stuff right over the phone. So they're insurance settlement brokers. They're salespeople of the injuries, right? Now that'd be like a car salesman actually saying, I don't need to know anything about the features of the car. I don't need to study the features of the car. That's the damn engineers. They geek out on that stuff. We rely on them. I just sell the car, right? That's what they're saying when they say, I don't need to study the injuries. I rely on the doctor. And I say, let's say an attorney wants a settlement, they want $1 million from an insurer. They want $100,000 for an insurer. And they want to say, this is so damn significant, but it's so damn significant, I don't have to study it. Other people have to study it. I mean, it's ridiculous what passes off. So what I'm saying is when you know those 3 injuries, you can start to lead the blind, because it's a very blind leading the blind market. So if I were to go to the next, the next thing is not acknowledging the permanency of a condition. So permanency in an injury case is this condition permanent or isn't it? Now, one of the things that we rely on for permanency, because we have this thing called objectivity, and objectivity is anything that can be verified, right? So if we have a written guideline for permanency, then we have objectivity because anybody can read it. I remember back in 1995, the first time I read the AMA guides to permanent evaluation of permanent impairment, which should be called the AMA guides evaluation to permanent injury, because there is no impairment without an injury anywhere in the body. So injury and an impairment is a derangement of a body part. That's what you go look it up in the AMA guides. What is an impairment? It's a derangement of a body part. What is a derangement of a body part? It's an injury, right? Remember when we started off the talk, you can't injure a body without deranging it.
Right.
All right. So now we have these permanent impairment guides. 1995, I read it for the first time. I was like, oh my God. The AMA has validated chiropractic, the body of chiropractic, better than the than the chiropractors have. We have done it to ourselves because they said a subluxation. Now, some of you are going to think this is a little bit controversial because there's a hypermobility aspect to this. They said a rateable or alteration motion segment integrity, which is nothing more than a spinal subluxation, is a 25% whole person impairment. So if somebody has it, 25% of their activities of daily living are somehow going to be negatively influenced. The first time I read that, I was like, oh my God, look at how much they validated what we do as chiropractors. But what do? Do we take that hand? Do we take that, oh my God, look at how much they validate it? No. What we do is we fight about it. You can't adjust that. You can't adjust that. How do you measure it? Oh, they didn't measure it accurately. I measure it this way. We measure it this way. And all of a sudden it gets dispersed into nothingness. And we don't take advantage of it. And it's ridiculous not to take advantage of it. It's ridiculous. For me, I've gotten to the point, Todd, where my profession is so self-abusive and they're so into self-minimization. Like one of the things on the coaching that a lot of times I have to coach is stop self-minimizing yourself. I'll show you guidelines. I'll show you, hey, in this permanent impairment guideline, this condition that we deal with every day, they're saying is super significant. Now, just like what you said, when you have a permanent condition, like an alteration motion segment integrity, you're saying, hey, the level, in this case, the person had 4 levels. Other guideline, remember guidelines, interesting thing about guidelines, and I know I'm rambling just a little bit, but it'll make sense. Guidelines are senior to research. Let me say that again. Guidelines are senior to research. Guidelines are like laws. A person can say, well, we should have a law. You know, there's still a law in the books that says that you can't, I don't know, you can't jaywalk. But everybody jaywalks. Well, good. Until that law is reversed, it's still the law. You can say, hey, we've done studies, 4,000 people a year jaywalk. Okay, whatever. It's still the law that says jaywalking is illegal. Right. So when you have a guideline, whether it's a chiropractic best practice guideline, or it's an impairment guideline, or it's a surgical guideline, people get together and they take all the research that they can find in a committee. They use research tools to screen for the research, and then they build the best guideline that they can determine. Right. So that becomes the law. Now, somebody else can say, well, there's new research that says this or says that. Fine. The guideline still states this. So when you're in the injury world, guidelines are important because guidelines make it so you don't have to argue. Right? One of the things that I say, Todd, and I know you're super good at this, is when you're in a deposition, you want to stay on offense. And offense means that you're not defending. What do you have to defend? I got the blind leading the blind over here that are asking me questions, right? And like, what am I going to defend? Like, I'm just going to state the obvious, but guidelines help to state the obvious. Dr. Cronk, are you saying this is 25% whole person impairment? No, the AMA guides is stating that. Dr. Cronk, are you saying that this is a surgical case? No. See the qualifier here for the surgical case? This guideline states it's a surgical case. Dr. Cronk, are you saying that all your treatment was within a normal realm of treatment? Yes, but I'm also stating this guidelining is also stating that. Right. So I'm using objectivity in front of me always. And when you're dealing, so one is knowing the injuries, 2, knowing permanency and being able to communicate that permanency, and not just its alteration motion segment integrity, because there's a whole hell of a lot more than just alteration motion segment integrity, but it's getting that permanency. And then it's also, and the last thing I'm going to say on the permanency is just because the condition is permanent. If a person's in an auto accident, they compress a C5 vertebra by 25%. Is anybody going to fix that? No, it's permanent. Good. Is anybody going to fix it? No. So there are people out there that say, well, if it's permanent, you shouldn't treat it. It's like, wow, that's asinine. So the person's got a 25% compression fracture and they get shunned because the idea is, well, you can't treat it. Can you treat factors around it? Yes. In treating the factors around that permanent condition, allow it to stabilize and allow the patient to have a much better life as a result of it. Yes. But we need to also assert the fact that there's too much evidence of the significance of the conditions that we treat on a daily basis that we simply don't take advantage of.
You know, taking everything you said and just transition this a little bit over into how we explain this to a patient, or how I would explain this to an attorney, or if I was in court. Side note, we should talk about this at some point. Tuesday I was in court. I went to court this Tuesday. It's last Tuesday. I don't know if I told you about that, but I was in court Tuesday as an expert witness, and I gave my expert testimony. And so I was questioned by the attorneys that I'm working with
Yeah.
to
Yep.
to defend a chiropractor who was, I think, wrongfully sued. And then I got cross-examined by their attorney, and man, it was a joke. I mean, it was like I sat there going, I could be a better attorney than you.
That's it. That's
Yeah.
it.
It was like everything he asked, I felt he was telegraphing what he wanted to trick me into saying 10 minutes
Correct.
before. And it was so easy to just dance around him. And he backed off, had nothing else to say. And then my attorney, their goal after you get cross-examined is to come up and clean up any damage that happened. There was no damage. So he came up and was like, I don't really have a whole lot of questions. And then afterwards, when we broke, he was like, every time you answered a question, we were all high-fiving each other, in the front underneath the table, because it went so well. And maybe towards the end of this, we can chat about that. I was thinking of doing a whole podcast just about this whole thing, which was a lot of fun. I like doing.
I would love to.
Yeah. I like doing expert work. This is like the 5th or 6th case I've done. These attorneys said, we're definitely hiring you for more stuff. I said, bring it on. Fun stuff. But anyway, back to what you were talking about, how I would relate this to a patient, as far as, you were saying, hey, if there's like a 25% compression to a vertebral body at C4, do we shun them and not take care of them? Kind of like someone who got like a COVID shot. Now they have myocarditis. No one wants to touch them, right? Because you said not to, which we could do a whole podcast on that too. But the way that I explain this to a patient, because I actually go through this on our virtual appointments, which is a whole other thing that we've talked a whole lot about, of when we do x-ray review, when we go through recommendations with a patient, we do it via Zoom. I did 2 of them this morning, actually, prior to jumping on and doing this podcast with you. But what we do in our workup, we take bending x-rays of the neck about 99% of the time. So we're taking flexion extension x-rays. And if there's more reason to do so, we'll take upper cervical lateral bending. Less commonly, we'll take lumbar flexion extension. But the most common thing that we're doing is cervical flexion extension. I mean, we take them all the time, not just in car crashes. Yep. I mean, it's all the time, because we're not just doing that for the car crash. We're doing this for patient care.
Correct.
All right. And so going through and looking at that, and then measuring, is there a instability as far as with translation or excessive rotation, excessive flexion or extension at that segment? I'll go through and explain that to a patient, and I'll explain that. And that helps them better understand their injury. It helps them better understand the significance of what's going on. Sometimes someone has a fairly normal looking cervical curve when they're looking straight forward, but when you bend them, the thing moves around like crazy.
100%.
And that's a problem, right?
Yes.
And so the way that we treat that clinically, because I know a lot of doctors like, okay, so what do you do about it? Well, let's say it's C4. Okay. So let's say C4 is translating excessively. On extension, it goes backwards 3.8 millimeters, and on flexion, it goes forward 1 millimeter. So you got 4.8 millimeters. That's massive, right?
Yeah.
But on a neutral, it looks okay. It's not,
Correct.
It's not a massive kyphosis. It's maybe just like a 20-degree cervical curve instead of like a 30 to 42-degree curve, which is more ideal.
Yes.
Okay. So, but when you flex and extend them, you'll see, and you see this pattern almost all the time, you'll see like C6 is not really moving a whole ton. C7 on T1 is extremely fixated. It's not moving well at all on flexion and extension. And then you'll see when they bend the neck, you don't have a good rate of uniform curve. So you don't have a nice smooth curve in both directions. You can almost see where it's notching in the neck and where it's stuck and where it's not moving. And from a chiropractic standpoint, it helps hone in on, hey, those are probably the areas that are most restricted that you want to get moving better to take the stress off the area of excessive motion that's moving so much. And then, so from a adjusting standpoint, that aligns a lot with how we've been trained in Gonstead. Like most subluxations people are having is in the cervical thoracic junction. You know, it's at C6, C7, T1, right? And then that hypermobility that's moving so much, to kind of go back to what you were saying, can you adjust a hypermobility? Should you ever? My answer to that, even from a Gonstead standpoint, is that just because a joint is hypermobile or moving in a certain direction excessively, is it moving in every direction excessively? Or are there things you can do from an adjustment standpoint, not just from a stimulate mechanoreceptors to try to create some stability, but from a standpoint of actually trying to get the joint mechanically moving better? I still feel like there's a huge need to work on a hypermobile segment at least a few times throughout someone's care. Now, for me personally, am I going to go in there and be adjusting that hypermobile segment every single visit when there's other joints that are way more restricted, 2 or 3 segments lower? No, I'm going to work on the ones that are more restricted. But from time to time throughout their care, there's absolutely times that we have to go into that joint that's moving excessively and adjust it. And there's typically a benefit to the patient for it.
Right.
Okay.
So we're drifting into technique. So I'll drift into technique with you just a little bit. I'm
All
gonna
right,
stay
let's do it.
super. I'm gonna stay super. I'm gonna stay in like a 30,000 view, because
Gotcha.
one of the things that technique should be is it should be repeatable, and it should be the assessment used should be uniform, so that whatever assessment, if a person goes into a dental office with a cavity, they're gonna pick, softness, x-ray, drill, fill. And you're going to get it in any dental office in the country. It's going to be the same. That's why their profession is so dramatically high. The amount of money that the dentists make is very good, and the standardization in dentistry is super high. Now, those where the standardization is super low always struggle. Right. So if I want to go into alternative treatment, right? I grew up in Seattle, spent 17 years in Seattle, a lot of alternative treatment, but you see a lot of poor alternative treatment providers. And then you'll see some guru who makes good money, but none of it is replicatable. Right. So he's got the art of the thing. So in order for chiropractic to grow up, right, and a third of 1% is not, in my opinion, growing up. Like 10% of the market would be growing up. In order for chiropractic to grow up, whatever's being said on we do a hypo and this is how we assess for it, and we take the assessments, and these hypos are 3 segments down from the hyper, and okay, I've heard this. I could listen to you, Todd. I could listen to 25 others, and we all could, and it's like all different. It's all different, and none of it is reproducible. Right. So what I mean by that is that there's no standard. Like if we went into an office, one of the things I did, I spoke at one of the largest defense firms in Michigan. This was 15, 17 years ago. When you talk about defense work, defense company, largest defense company, State Farm, Allstate, Auto Owners Insurance, everybody else had this big group together, and they said, "Hey, Dr. Cronk, come in to speak about ligament injuries." I felt like at first it was like the Sith Lord inviting Luke Skywalker into the big event for the Sith Lords. You know what I mean? All the stormtroopers were going to be there. And it was like, this seems like a trap. This is a trap. The Yoda's on my right ear going, "Hey, it's a trap. It's a trap." It's like, no, I'm going in. I think I can use the force. So I basically go, okay, no, I'm going to go in and teach them. And I'm going to teach them about injuries in 1 hour. Spinal ligament injuries, my whole considerations about why would they ask me? I'm one that shows the significance of these injuries, right? So I'm up there. They give me an hour. I got like 175 people, claims adjusters, IME, special investigation units, defense attorneys, all this stuff that is the counter in the market. They're my audience, right? So I started off and I say, look, what I'm going to be talking about today is a condition called a ligament injury. Any of you that suffer from chronic pain, You don't have to raise your hand, but about 50% of you in this audience right now have some form of chronic pain. It's due to a ligament condition. You don't have to raise your hands. Just listen to what I'm saying today because you've never had it diagnosed. And that's why you don't get help with it. Right? And then I explained exactly what I teach doctors to explain. I explain the condition. Now, I don't need to go into adjusting hyper, adjusting hypo. I do this, I do that. Because the other thing that I explained is that there's no standardization of procedures. That's why you all in this room are so confused. If an injury patient goes into a hospital, they get this kind of a workup. If an injury patient goes to an outpatient specialist center, they get this kind of workup. Orthopedist, this kind of workup. Neurologist, this kind of workup. I said, what about the chiropractors? Right? They thought I was a medical doctor. I said, what about the chiropractors? Go in, any patient go into any 10 offices and look at the standardization of the notes. There's none. They laughed. They thought that was so funny. Right? And I went, yeah, it is funny because it's the key thing that needs to be fixed in order for the profession to expand. It has to be fixed. So when you get down to, can you adjust a hypermobility? My answer to that is 1,000% yes. Now, how much hypermobility? There's the area. The majority of what an average chiropractor sees does not extend into that, wow, I've got 9 millimeters of translation on C1 and C2. I have 6.7 millimeters of translation on C4 and C5. I have, 37 degrees of angular finding on C3, C4, right? You're not getting into those super catastrophic type numbers.
Mm-hmm.
So what are the numbers? Because I can 100% guarantee you, as somebody that's looked at excessive motion x-rays for the last since 2005, and prior to that from 1995 to 2004, with every case in my own office, I can 100% assure everyone that's on the podcast today that you are adjusting hypermobile segments on a regular basis. Now you can say, are the Atlas orthogonal guys doing it? Yeah, 100% on just in one joint, right? Gonstead, you have different techniques, and that's not to say there's no problem with the techniques, but because the techniques are all different. So some of them are more specific.
And it's even defining too. And granted, I know your statement, can you adjust hypermobile segment? Is it happening? Absolutely. I would say that's absolutely correct as well. And then you get people saying, well, let's define it and let's geek out on all this. And that's the stuff that does need to be standardized. I think I'm biased. I think the way we practice is very correct. I think we should be more of a standard of how the chiropractors do it as well. But like even in Gonstead, for example, in Gonstead analysis, when you're looking at a lateral neutral cervical x-ray, we're taught to look at which cervical, like in the lower cervical spine, typically is where you find it, but it could be anywhere, is more extended. And the joint that extends the most is the one that is theoretically subluxated posterior inferior. Now, if you do bending x-rays on that person, most of the time, that joint that looks more extended and neutral actually slides and translates posteriorly. When you go into extension, that's excessive motion, but it's excessive motion in posteriority. And in Gonstead, we're adjusting from P to A, from back to front. So it still follows that like really simplistic chiropractic thing that we learned in school. I'm guessing that you probably learned this in school too. They used to say easy into subluxation, hard away.
Yeah.
So it's like a joint's going to move more into the subluxated position, into the excessive motion position, and it's going to be harder to go the other direction in a lot of cases. So yeah, I mean, I know that we're getting into like,
yeah, we don't have to
philosophizing in this whole thing, but
no, we don't have to stray into that because the bottom line is this. Like when I look at it, if there's 60,000 chiropractors, let's say they treat an average of 100 patients a week, which is not. I mean, there's going to be some that are way above. You're talking about probably 5 million, 6 million adjustments a week. You're talking about malpractice insurance is probably $79 a month for 3 mil. Right? So what we have to do is we have to realize we're not hurting people. We do not hurt people on a regular basis. We're super, super safe. No matter all these theories about the adjusting and I do it here and I do it there. That's all great. Just don't go after somebody because they might do it or say it in a different way, or they might address it in a different way, because we're addressing, I mean, if I go back to the Mercy conference, which is how chiropractic got inclusion in insurance in the first place, Houston conference, sorry, not the Mercy, the Houston conference, which was, I think, in 1973, which the parameters of a subluxation were integrated into Medicare, and that's the first insurance inclusion, and then all the other insurers came in. There was 17 subluxation patterns. I would say half the subluxation patterns were abnormal motion, hypermobility. So if we can't adjust hypermobilities, one, then we need to be out of the injury market, because that when you're talking about injuries, you're talking about hypermobilities. And when somebody says, well, it's not, no, I can feel it's fixated. Good. So if a guy sprains his ankle and he comes in with a fresh sprained ankle and it's a bad ligament damage to the ankle, when it's freshly sprained, if you were to palpate it, is it going to seem hypo or hyper?
It's extremely fixated, hypo.
Extremely fixated.
Yep.
Are you not going to adjust it? Yeah, you might decide to do an extremity adjustment with it. Good. As you go and that inflammation goes away, are you dealing with a hypo or a hyper? You're dealing with a hyper. Right? So we have to get out of those conversations, though. Those conversations drag this whole profession down. Because it's just they're tough conversations to have, because they don't have resolved solutions to them that can standardly be applied. So we need, like, I'm a guy that says, well, let's go with the things that can standardly be applied. Good. They need to be adjusted. Beautiful. I mean, all our science is a clinical science, is empirical science. Empirical means you're observing the science in real time. When you adjust the patient, you observe the result of your adjustment in real time. And I've done 1 million adjustments, right? I have had times. I had a time one time, I remember it very, very well. I adjusted a patient, they couldn't get their head off the table, right? They had to put their hand behind their head and lift up. Now, is that the response I wanted from an adjustment? No. Was that the response that I got from the other 999,000 adjustments that I did prior to that? Or the 659,000, wherever it was in my career? No. Did I empirically go, I observed something that I need to pay attention to? Yes. Did I change my adjustment technique on that? Yes. Did the patient get results? Yes. So it's an empirical science. It's right there in front of you.
I think the way that we went down this wormhole, just so I can complete
permanency. No, permanency. We were on permanency and permanency of ligament damage, and then we got into excessive motion.
It was that, and it was just, I was sharing with that how I explain this to a patient. I don't get into all the minutia with the patient as far as this, but I show them. And the main point I was trying to make is that a neutral can look decent and a flexion extension can look crazy. And that's why you have to be taking these x-rays on people, because you're going to miss so many of these injuries.
Yeah. Not to see is not to know. There is no way to know unless you can see it.
Mm-hmm.
And when we can see things, we can standardize them, because we see the same patterns over and over and over again. Anybody that looks, I mean, I don't know how many x-rays I've looked at. Anybody that looks is going to see the same consistent patterns. Good. You can build standard procedures on what you see consistently.
And that's essentially what we've done clinically is, there's certain attributes to what you see on bending x-rays that help just complete your treatment strategy. For us doing corrective care and curve correction, it helps you understand where the fulcrum needs to be placed to start to restore the curve. And various exercises that need to be targeted at trying to maybe increase more of a bend in the lower cervical spine. If it looks like it's really restricted, not moving, where more mobility exercises should be done. I mean, it's very logical, and it all comes together and it works really well.
Yes, 1,000%. So going back to your 1,000%, that's what I love about what you guys do too, by the way. So 5 things we said, because I don't know where we are in podcast wise or your time wise, is knowing the injuries and simplify them, work them up correctly, using guidelines
Mhm.
determine permanency, and using guidelines to tell the story of the patient, even though the effect of the condition is not going to be permanent. That's your job. That's my job, and your job as a doctor is to take a permanent condition, C5 compression fracture. Good. Wait till it heals. Now, can you do things chiropractically and rehab wise that are going to make it so that patient may not have to experience any problems with this C5 compression fracture for the rest of their life? Yes, that's your job.
Mhm.
Right. So just because something's permanent doesn't mean the condition or the symptoms have to be permanent. The internal deranged condition may be permanent, but how the patient lives and what they experience, that's not permanent. That's dynamic. That's our jobs to fix that. So, but you have to document that. Then other thing you have to document really well, 2 things, this would be point 3 and point 4, is you have to document things that the patient can't do as a result of their injuries, or things that they can do, but it causes them trouble.
Which is LOE and DUD.
Loss of enjoyment of life and duties under duress. Yes, LOE and DUD. So you got to document those things.
Mhm.
Right. And then what I'd say is the last thing is, if a person has a permanent condition, remember, if a person has a permanent symptom, I permanently got headaches. Are you going to say, well, that's a permanent condition? Well, what's the condition? Because the condition is a symptom, where that you're saying, I got headaches. Good. That's a symptom. But what is the root cause that is a thing that's permanent, that's causing that permanent symptom? See, I don't get permanent shortness of breath unless something's malfunctioned. Nobody's going to go, oh, he's got permanent. His diagnosis is permanent loss of lung function, right? Permanent shortness of breath. What's the shortness of breath cause? It's caused from permanent shortness of breath syndrome. Okay. God, that's great. Oh, what do you have? I have permanent loss of breath syndrome. What do you have? I have permanent headaches. They're permanent headaches. Good. What's causing the permanent headaches? Doctor, we got to get back to doctors of chiropractic are the doctors of cause, not of symptoms. They're getting down to the root cause of the condition. If I have a heart condition, I want the cardiologist to treat and ongoingly help me with my heart. Now I'm going to do other things for it. Obviously, if I had a heart condition, I'm going to do other things for it as well. But you're looking at these things and you relate them down to what's the root cause. Man, when you do that, doesn't matter if you have an injury practice or a non-injury practice, you're going to have a hell of a big practice and you're going to grow 100%. So rounding this out, injuries themselves, permanency, the effect called duties under duress or loss of enjoyment of life. If they have a permanent condition and they have continuing problems, then you also have to document what's your future care recommendation? What in the future do they need to do? We talked about mobility kits. Good. They need to actively continue to use their mobility kits, their home exercise procedures. They need to actively continue to do that. It's going to be good for them. That's a future care recommendation. They're going to need to see a doctor of chiropractic on 2 times a year, 4 times a year, 6 times a year. I recommend for the next 2 years. Doctors don't recommend. One of the things I see on recommendations of future care, matter of fact, I was working with this doctor and he was a wellness doctor, and it's fine, great. His idea was that every patient should be treated once a week for the rest of their life. I'm like, okay, but it's going to be hard to say you did 30 visits of injury care and now the patient needs 800 future care visits in order to maintain the 30 visits that you did of injury care.
Mm-hmm.
So you want to take because situations change, right? So in my experience, I just would go out for the next 2 years. Hey, I could forecast pretty accurately the next couple of years what the patient should do. After that point, I'll make a better determination. So you're not, the last thing I'll say on that is the insurance company is not your enemy. That was one of the biggest aha moments I had in my own private practice. Was I was sitting there in my office on a Saturday writing scathing reports on an IME that I just gotten, going, God, I'm wasting my Saturday with my family writing these damn reports, 20 pages, blah, blah, blah. And all of a sudden I'm sitting there going, wow, I have a 5,000 square foot house. I have rental properties. I make really good money. I can go wherever I want to. My family can go wherever I want to. I provide for my family really well. And the insurance companies are paying for all of this. So why am I so scathingly attacking them? As a matter of fact, I'm really aligned with them. What they want is all the injuries diagnosed properly. Then they want really good treatment so the person doesn't have long-term negative effects from it. I'm like top of the line at that. And they want it done as fast as possible so it doesn't go on. I'm aligned with the insurers probably better than I'm aligned with the attorneys. And in that point, I stopped having the insurance industry be an antagonism for me. I'm aligned with them. I'm also aligned with that personal injury attorney. If you do good injury work, one of the things, Todd, is injury doctors think, well, gosh, I got the patient well too quickly. I didn't raise claim value. That's the one I love. Oh, I'm going to teach the attorneys how to raise claim value. When I hear a doctor say that, what I hear him saying is, I'm going to teach an attorney how we really mess the patient up, because the more benefits they need, the worse the results they got in care. Right? So if a patient comes into your office and they're in a wheelchair, doctors who are listening to this right now, they're in a wheelchair. They went to a medical doctor. They were in a car accident. Nobody knows what's going on with their lumbar spine, but they can't get their butt out of that wheelchair and they can't walk. Right? They come into your office. They heard, oh, wow, Gonstead Clinic is where I want to be. I've heard nationally, I've heard people talk about Dr. Todd Pickman. Right? Good. Wheels into Dr. Todd Pickman's office, right? If the attorney settled a case with a patient that can't get out of a wheelchair, is the claim benefit higher, or is the settlement going to be higher or lower? It's going to be higher. Good. Now they go through Gonstead Wellness, right? Dr. Todd Pickman works as manager. 6 months later, this guy's running in Meridian, Idaho. He's running 10K runs. He doesn't even know he had a back injury. Is that the ideal scene for the patient? Yes.
Yep.
Did we lower the claim value? Yes. Did we lower the benefit that the patient may be entitled to? Yes. Is everybody happy? Yes. The attorney's happy. The patient's happy. The insurer's happy. You're happy. Everyone's happy when we do that. And it doesn't get talked about enough. That makes sense? I didn't give you a binger there, did I?
I think that's a good mic drop
Yeah.
ending right there. That's good.
Perfect.
No, it's true. And ultimately what it comes down to, and why I immediately gravitated towards your work, was because it's about patient care. It's about excellence. It's about doing a great job. It's not about how do you do this sleazy personal injury work and make as much money as possible and screw everyone over and ha 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 ha. And that's the way that a lot of people think about auto injury stuff.
That's also why I gravitated to you too, because you don't think that way at all. And everything that you built in your programs, that's why, for me, Todd, that's why we connected, because it was aligned there. We were really aligned there, because doctors, and Todd, you know this as well as I do, you can make a fortune in clinic, or having multiple clinics, or grow your business however you want to. Results will make it go a lot easier. And with results comes everything that you want. It comes attorney relationships, better relationships with insurers. It comes with better referrals. It comes with better being looked at in your status in your community. Everything improves with that. Everything improves with that.
You want to know what our tagline is for our clinic?
Yeah, go ahead.
Gonstead Spine and Wellness, right on our business card, right underneath it, it says results matter most.
Exactly.
That's what it is.
Results matter most, man. If you lead with results, because the other thing that, why we migrated, or why we connected, is you are at the front of the bell curve. You're at the top 10%, maybe even the top 2% of chiropractors in the country. So you're at that top percentage of the bell curve. And that's where all of us want to strive to be. We want to strive to be in that top, because if you're in that top, it doesn't matter where you go, you're going to be successful. It's kind of like, hey, if I take Aaron Judd, right? He hit 62 home runs, right? He's at the top of his game. People will fight over him. That's because he's at the top. If you looked at a bell curve of home run hitters, he's at the very front of the bell curve, right? They go anywhere they want to. So you always want to strive to get to the top at whatever you're doing. Get to the top of it.
Yeah, that's great. Well, look, I think time-wise, I think this is probably a perfect spot for us to wrap this up. And I definitely want to do this again with you and focus on other specific topics too, because obviously there is a ton of knowledge you have and great things to talk about. I mean, I've talked to you multiple times, and just in us going through this podcast, there's some things I picked up and I'm like, yeah, that's good. Or like, I like how he worded that. I like how he said that. So yeah, it's always great connecting with you and talking with you. And I'm sure all of our listeners out there are really going to love this episode and get a ton out of it. Now, please let those out there know, how do they get a hold of you? Is there a Facebook group that they can hover around in and check stuff out? What resources do you have out there?
Yeah, so we have a Facebook group that's called Smart Injury Doctors.
Which one is it? Because there's two, right?
Yeah. Smart Injury Doctors Practice Building Network.
Okay.
That's the one. They can call us at 800-940-6513. You can also go to the smartinjurydoctors.com website. When you come to us, let us know that you heard us on a Move Now You web podcast, because we do something special for those of you that come in via Todd's portal. So let us know that that's where you heard about us. We ask, but let us know that's where you heard about us so we can do something special for you. But that's how they would get a hold of us.
Awesome. Cool. Well, thank you so much again for jumping on and for you taking the time, because I know that you are a busy guy. So I really appreciate you taking all this time. I mean, this is a good episode. We talked for over an hour, which is great. So I am going to run the outro for everyone listening, whether this is your first time listening or you listen every single week. We have a book that you can get called Move Well Secrets. It's a free book. We'll ship it to you. That's book.movenowyou.com. And then we have a 30-minute behind the scenes demo that shows how our program works as well. We actually have a section in there all about smart injury doctors, because we definitely promote, like, if you're going to do personal injury work, you got to do smart injury doctor stuff. There's nothing else out there that's better. So listen to our outro. We have some of those links repeated. Appreciate you taking the time, everyone, not just you, Dr. Cronk, but our audience as well, because you're the ones that motivate us to do what we do. So we appreciate everyone out there, and we're going to roll the outro. Here it goes. Want more Move Now secrets? If so, then go get your copy of my best-selling book and watch my 30-minute behind-the-scenes Move Now demo. My book is called Move Well Secrets, and you can get your free copy at book.movenowyou.com. and watch the 30-minute demo of our exclusive doctor training portal at demo.movenowyou.com. With these two resources, you'll find my top 22 secrets that we've used to build one of the smoothest running, results producing, and super profitable exercise departments within a chiropractic clinic in the entire profession.